For the last abstract will be presented by our co-chair Fatima on the long-term risk of hospitalization and chronic disease among children who were HIV exposed and infected compared to the population controls in Montreal, Canada.
Thank you so much. And so after really touring the world this morning with some great presentations, I'm glad I'm able to bring it back to Montreal and present to you these findings that have been years in the makings, and we finally have results that we're able to share. So I think this group knows this subject matter very well, but for those who may be less familiar, we're all pretty much sensitized to the issue that children who are HIV exposed and uninfected have really been shown now across multiple cohort studies and here at this meeting multiple times to be at increased risk of morbidity and mortality when compared to population controls. And really, a number of studies have shown this across multiple domains, including hospitalization risk, infectious diseases, poor growth and stunting, and specifically neurodevelopmental with speech and language delay. I'm having a little bit of trouble. Next. And the cause is likely multifactorial. I know so many groups have been studying this these last many years and trying first to document what specific outcomes, and there's really good data to show these specific outcomes on the right. And then there's also groups looking at mediator mechanisms, and we know what potential infant mechanisms may be contributing to these outcomes, and also what potential maternal factors, specifically ART, HIV exposure. But one thing that's consistently come up across these studies is the question of, is this all related potentially to poor access to care? Are these children coming from really difficult socioeconomic status that's leading to these adverse health outcomes? So it was a natural question for us to think, in a resource-rich setting such as Canada, would we see these same outcomes? Next slide, please. Next slide. So the objectives of our study were really quite simple. We wanted to look at the incidence rate of hospitalization among children who are HIV exposed, uninfected, compared to population controls here in Montreal, and next to look at the risk of any chronic disease among our cases versus controls. Next. So this was a cohort study in which we linked two different cohorts. So this is our local CIMS Montreal cohort of HIV-exposed children. So this was established back in 1988 at Sainte-Justine Hospital when it didn't look quite this modern, but it was at a time where Montreal was really at the epicenter of the beginning of the HIV epidemic. And with a lot of forethought, this cohort was established to offer entry at diagnosis during pregnancy to mother-infant pairs, and children were followed from birth until early childhood. And so these children are some of the oldest HIV and ARV exposed children in the world. And we're very privileged to be living here in the province of Quebec, where we have a unique healthcare system that's called the Régie Assurance Maladie du Québec, the RAMQ. And it's a universal healthcare system that covers all residents of the province regardless of income. We all have equitable healthcare, and at birth we're assigned a unique patient identifier that follows us for life. And so this RAMQ database contains all medical services that are attributed to a single individual, whether inpatient, outpatient, or any setting. And so, for example, my RAMQ number is associated with every hospital or every clinic visit and every diagnosis I've had in my life. And so after many administrative battles and a lot of challenges, we finally had the permission to link our local data set to the provincial administrative data set to obtain individual level data for all of our children after they had left our care. And so our cases were also matched 1 to 3 to an HIV unexposed, uninfected control that was selected at random from the RAMQ data set after matching for age, gender, and postal code. So we felt it was really important to match for postal code, to match as much as possible and to adjust as much as possible for socioeconomic status. And even though we're in a very resource-rich setting, so this is a map of the island of Montreal where you are currently that's divided up by postal code. And within the postal codes, we have an index of the socioeconomic status by revenue. So in dark red are the wealthiest neighborhoods, in dark blue, the poorest, and the pale is the median Canadian income. And so you can see that there are huge discrepancies within the very same small island we live on. And just to situate you, you are currently in what we call the Golden Mile area of Montreal, aptly described in dark red. But not far from us are some areas which have a much lower average income. And so the primary outcomes we looked at were hospitalization, any hospitalization in the province of Quebec that was registered in the RAMQ database. And then for chronic conditions, we determined these by system that we looked at a priori based on plausible mechanisms that have been described, for example, in animal models and specifically related to ART toxicity, and really after reviewing the existing data among multiple cohorts to see what signals had come up from other cohorts. And then we categorized these by disease system according to their ICD-9 codes, and these are extracted from the RAMQ data set. We did survival analysis with proportional hazards to compare the incidence rates of all-cause hospitalizations between our cases and controls. And for the outcomes of chronic condition, we looked at risk ratios and confidence intervals for the first occurrence of any of these conditions within the two groups. So this was the output that we had from the RAMQ data set. So these are our cases and our controls. We had 726 CHEUs who were matched to just over 2,000 controls. And as planned, there was an equal distribution of female sex at birth and follow-up time. What we hadn't anticipated was that there was a significant difference in gestational age, so there's a higher risk of preterm birth at 13.7% in our cases versus our controls, indicating that this was something we would need to adjust for moving forward in our analyses. Next, please. And just to give you a description of who the children in our cohort are, because we don't have this level of data for our controls, but this is a very old historical cohort, so many of them were exposed to many older regimens. So the vast majority were exposed to AZT and 3TC in utero, but we have some that were exposed to just AZT monotherapy, some of the older DDI, D4T drugs, and just a very small number that were exposed to abacavir or tenofovir. And as far as really the core of the regimens, the vast majority were exposed to either boosted or unboosted PIs. And we had very few, 1%, who had actually, at this point, been on the newer integrase inhibitor regimen. So really an older cohort. And we had less than 20% who were born before the year 2000, and then about a quarter each for the next periods. So this is our first primary outcome, which is the risk of hospitalization over time. And I was surprised to see this, but it does confirm what other cohort studies have shown, is that even here, our exposed children had an increased risk of all-cause hospitalization over their lifetime with an unadjusted ratio of 1.4. And this decreased to 1.23 when we adjusted for gestational age, but across the lifespan, this was evident. And then we did a sensitivity analysis where we excluded a prolonged birth hospitalization, so any hospitalization beyond 5 days, which was considered a neonatal complication. And this reduced the hazard ratio to 1.2, which did remain significant, but when we adjusted for gestational age, really became borderline significant, suggesting that there is something with respect to prematurity and that prolonged birth hospitalization that may be contributing to this risk. Next, we looked at outcomes by systems domain as we defined them by their ICD-9 codes. And these were the different systems, and I'll go into them in more detail as I present those results. So this was the first major system where we looked at neurodevelopmental and psychiatric conditions. So first, we put them all together, and these were the specific conditions within each group. And we did see a significant increase in these diagnoses in our exposed kids with a relative risk of 1.28. Now, this next slide is what I was most shocked at, and in hindsight, I shouldn't be, because I've been following these kids for years, and neurodevelopmental diagnosis is really the primary healthcare concern I see on a weekly basis. But I was really surprised at the magnitude of the effect. So in some domains, for example, intellectual disability, our exposed children had an over 4-fold risk as compared to controls. Psychoses, 2-fold. Autism spectrum disorder, 1 point, almost 2. Coordination disorders at 2.29. And even when we looked at global delays in development at 12%, there was an increased relative risk of 1.4. And my team and I are looking at these results, and unfortunately, it does match what we see on a clinical day-to-day basis. Next, we look at congenital anomalies, as we're always on the lookout for congenital anomalies in relation to ART exposure. So we looked at these and categorized these by system, and we did see an increased risk in our exposed kids compared to our controls. And when we broke those down, the primary risks we saw were in atrial septal defects, so 8.4% versus 2.8% in our controls, and in congenital musculoskeletal anomalies, but this was primarily polydactyly, benign polydactyly. at 14.7 versus 10.8%. And again, it does match what we see on a clinical day-to-day. Next, we looked at growth and endocrine system disorders, because we're always wondering what happens to these kids as they grow up. Are they more at risk of autoimmune conditions and diabetes and metabolic syndrome, and really putting them all together. And this was really interesting because in this scenario, our exposed kids did better than their neighbors, their population controls. So when we broke this down, I found this fascinating in that indeed our exposed kids did better when it came to not being underweight or not having short stature or feeding difficulties. And I'd like to think that this is because they're under our really precious care and we're really taking good care of them as compared to their neighbors who may not have the same access. But one thing that I hadn't anticipated that was increased in our exposed kids was an incidence of diabetes. So at 13.4% versus 9.3% in our controls. Now I don't have the breakdown whether this is type 1 or type 2, but this was something unexpected and I think something worth thinking about further. Now in some good news, we also looked for signals with respect to chronic respiratory conditions, chronic cardiovascular conditions, and malignancy. And in this instance, we didn't see any signal of increased risk in our cases and our controls. And while this is a small cohort, it is reassuring when we look at all of the other signals that have come out that there's really nothing that seems different in these domains. So in summary, in our Montreal cohort here, we did see an increased risk in all-cause hospitalization in our children who are HIV exposed compared to controls. And these are really despite controls who are matched for their socioeconomic status, their neighborhood, their age, and their gender. And this was after adjusting for gestational age. I think the most concerning and significant finding of this study is really the increased risk of neurodevelopmental and psychiatric diagnosis in our cases. And it does confirm findings that we've all seen from cohorts from around the world. But I think given the millions of HEUs globally and the high seroprevalence in some countries, this is something that warrants further work and really needs to be addressed. There was an increased risk of some specific congenital anomalies, atrial septal defects and musculoskeletal. The musculoskeletal was largely benign. The atrial septal defects, I don't have the details at the case level, but just clinically, very few of our children have needed cardiac interventions. And there was no signal of increased risk of malignancy, cardiovascular, and respiratory conditions. So our study does have a number of limitations, the first and most important being that we've used administrative data. And so ICD-9 codes are great, but they're non-exhaustive, and they really reflect our billing practices and not necessarily clinical reality. And as well, there may be imperfect matching within neighborhoods. So we're looking at median incomes, but we may not have perfectly matched for socioeconomic status. And of course, there are multiple unadjusted confounders, such as breastfeeding, such as immigration, that we're not able to adjust for. And of course, our cohort is very old, and the kids had very different ART exposures over time. And many of them have been exposed to older regimens that are no longer used. So it's not clear that these outcomes will be something that will necessarily be seen now. But I do think one of the strengths of this study was the ability to link our clinical data to administrative data, which really allows for some long-term outcomes assessment of these children as they move into adulthood. And I hope that it can provide some insight into potential signals that really could be studied and assessed in larger cohorts, such as, for example, a possible risk of diabetes. So to conclude, I think while all of us are continuing to really work on trying to understand the causes of these differences in health outcomes between exposed and unexposed children, I really do think that these data suggest that children who are HIV exposed and uninfected would benefit from enhanced access to primary care regardless of setting. And I say this because even here in Canada, we have lots of money, but we're always being asked by our hospital administrators, why do you need to follow these children after they're negative? And the truth is many of these children don't have access to primary care pediatricians or not well connected to the system. So we're constantly using this type of data to defend the services we have. And so we really want to provide them with some ongoing care after their HIV negative diagnosis and really trying to push for increased services for early neurodevelopmental assessments and screening. With that, I conclude, but not without thanking our wonderful clinical and research team that has accumulated this cohort over the last 30 years. And it really wouldn't be a research cohort without the wonderful clinicians and clinical staff that have taken care of these women and children. And I'd like to specifically highlight our research nurse and coordinators and our data analysts who jumped through so many hoops to be able to get this administrative data and are now working diligently on it. So thank you.